This is amyotropic lateral sclerosis, where you will see both upper motor neuron and lower motor neuron symptoms, which are seen in subacute combined degeneration. There's Friedreich's ataxia, amyotropic lateral sclerosis, and multiple sclerosis. Also, you can see both these features. So SFAM, SFAM. So motor neuron disease is a type of disorder where the motor neuron is affected. The most common type of this is amyotrophic lateral sclerosis. People who suffer from motor neuron disease usually die due to respiratory failure after getting bedridden. Amyotrophic lateral sclerosis. Amyotrophic. So myo is muscles. There is denervation of the muscles. The nerve supply is lost. Damage to the anterior horn cells of the spinal cord is there. Therefore, it's a lower motor neuron lesion symptoms can be seen because directly this thing is affected. The motor neuron is affected. Lateral sclerosis is involvement of the lateral corticospinal pathway. It is thinning of the lateral skull. So because this is affected, for anything that's below this, there will be upper motor neuron symptoms seen. So upper motor neuron symptoms are like brisk reflexes or Babinski sign positive. Now pathogenesis of ALS is it is genetic. It can be either genetic or it can be sporadic, right? Sporadic किसी को भी हो सकता है. Now genetic में it is inherited as autosomal dominant disorder. Now the gene is SOD1 gene, which is superoxide dismutase gene. Or there can be hexanucleotide repeats. Hexanucleotide repeats are seen in amyotrophic lateral sclerosis of C9ORF72. C9ORF72. Hexanucleotide repeats of this thing. Now superoxide SOD1 gene controls the activity of superoxide dismutase. It controls and neutralizes the free radicals of the body. So if the gene is defected, the activity of SOD is decreased, free radicals increase, and they damage the anterior horn cells as well as the corticospinal tract. So amyotrophic lateral sclerosis can occur, leading to ALS. Hexanucleotide repeats of C9ORF72 is seen in amyotrophic lateral sclerosis, whereas trinucleotide repeat is seen in Huntington disease, where CAG is seen, Fragile X syndrome CGG, and myotonic dystrophy CTG. Trinucleotide repeats are seen. Now pathology, there is defective protein degradation in the neuron, if defective RNA processing, excitatory damage due to amino acids, excitatotoxicity, there is glutamate levels are increased and aspartate levels are increased. So પ્રોટીન જે છે એ ડિગ્રેડ બરાબર નથી થઈ રહ્યું, આરએનએ જે છે એ પ્રોસેસ થઈ નથી રહ્યો, અને આ જે એક્સાઇટેટરી ન્યુરો ટ્રાન્સમીટર છે એ ત્યાં જઈને આની વાટ લગાડે. તો ત્રણ વસ્તુ થઈ રહી, પ્રોટીન ડિગ્રેડ નથી થઈ રહ્યું, આરએનએ બરાબર કામ નથી કરી રહ્યું, અને એક્સાઇટેટરી ન્યુરો ટ્રાન્સમીટર્સ એને ડેમેજ કરી રહ્યા છે. ટ્રીટમેન્ટ્સ, યુ ગિવ રાઇલ્યુઝોલ that decrease both glutamate and aspartate levels, so it decreases the excitotoxic damage to the spinal cord. Then you can give foot drop splints, you can give physiotherapy, finger extension splint needs to be given, tracheostomy needs to be given because if there is diaphragmatic paralysis and the patient should not die out of respiratory failure. Cuff assistive devices should be given because bulbar palsy occurs, so cuff reflex is lost. So cuff assistive devices remove the mucus secretion that may be accumulated in the respiratory passages. The most common cause of death is respiratory failure or pneumonia. Clinical manifestation is asymmetric and gradual onset of weakness in extremities. Leg weakness, fasciculations can be present, which is a feature of low motor neuron damage. Knee jerk can be absent in one leg. There can be slapping gait that is present. Some patient after 1 year will develop hand weakness. Brisk biceps jerk can be present in case upper motor neuron lesion is present. Asymmetric weakness is present. Eye movements are preserved. Bladder and bowel movements is also preserved till late. Higher mental function is also normal. So HMF, bowel, bladder, eye movement are normal. Later you can have bulbar palsy where 9th and 10th cranial nerve can be affected, so the patient can't talk, can't eat, can't drink. 12th nerve can also be affected. If more than 3 or of the below 4 segments is showing the above mentioned features, then it's confirmatory of amyotrophic lateral sclerosis. So there can be bulbar where there is can't eat, can't drink, can't swallow. Cervical where there will be weakness of the arms and of the diaphragm. Thoracic can be present, lumbar can be present, which affects the legs and everything. Now workup, you can do serum electrolyte levels to rule out hypokalemia, hyperkalemia, or any electrolyte imbalance which is causing these weakness. Then you can do nerve conduction velocity to see if there is any demyelination disorder that's taking place. Then you can do CPK, MM or muscle biopsy to see whether there is any muscle damage on EMG. Denervation pattern will be seen on electromyography because the nerve supply to this is gone, which is amyotrophic. Like that's what denervation of muscles occurring. So denervation will be seen on electromyography. Then you can do anti-acetylcholine receptor antibodies, anti-musk antibodies, anti-VBIQ antibodies to rule out myasthenia gravis and Lambert-Eaton syndrome. Then you can do genetic study for SCN4A channels, and you can do serum and vitamin B12 levels because to rule out subacute combined degeneration, because upper motor neuron, lower motor neuron both were seen in SACD, Friedreich's ataxia and amyotrophic lateral sclerosis. Friedreich's ataxia also has a trinucleotide repeats of GAA. Then extra mild damage to the anterior horn swell, low motor muscular atrophy, lateral sclerosis, ALS. GBS, the lower motor neuron lesions will progress over 4 weeks. CIDP almost 9 weeks. ALS takes years to develop. Now, bulbar palsy can occur where damage to 9, 10, 11, 12 nerves happens. Because of this, patient can't eat, drink, swallow, talk. Bulbar palsy is damage to the nucleus, and pseudobulbar palsy is damage to the corticobulbar fibers, like from the cortex to the nucleus what is getting damaged. Now bulbar palsy is poor motor neuron lesion because the nucleus is damaged. Pseudobulbar is pure upper motor neuron lesion because the fibers are damaged. Gag reflex is negative because it's a lower motor neuron. Your gag reflex is brisk because it's upper motor neuron. The tongue is flaccid again because lower motor neuron, so the nerve supply is only lost. Tongue is spastic because the control is lost, so it's difficult to take it out. Other diseases with LML plus UML are SACD, Friedreich's ataxia, a motor neuron disease, or amyotrophic lateral sclerosis.